Good evening, everyone, and thank you for coming to this committee meeting this evening. We're not quite all here, but we're going to start and do the minutes and hope that by the time we've done that, everyone's online. So the minutes are on page 5. Oh, sorry, are there any apologies?
Councillor Margetts and Councillor Shepherd-Bay.
Thank you. I'll put my glasses on now, I should be better.
Sorry, I'm here for Councillor Margaret.
Sorry, Moses.
I'm substituting for Councillor Margaret Rebecca.
Oh, yes, yes, substitute.
Sorry, and also Councillor Smith is substituting for Councillor Shepherd-Bay. Thank you for that.
Okay, minutes of the previous meeting, page 5 on the paperwork. Alison, we've just started. Any questions?
We've got no questions.
Are you happy that I signed the minutes? Which I would if I could find a pen. Yep. Thank you. Are there any public questions? Oh, sorry, any declarations of interest? No? Any public questions?
No questions.
Any member questions?
No questions.
Item 43 on page 11, RBH Foundation Trust update, building Berkshire together. Andrew, you're taking this, I understand.
I am, yes, thank you. For those who don't know me, I'm Andrew Statham. I'm Chief Strategy Officer at the Royal Berks, and I've got the executive lead for our work on a new hospital, the Building Berkshire Together programme. So I'm sure that people around the table will be aware that on the 20th of January, the government announced the outcome of its review of the new hospital programme. That outcome has meant that the rebuild of the Royal Berks Hospital has been delayed and won't start until at least 2037. We've also been told that because of the extended delay there, that we won't get access to funding to progress plans until at least 2030 at the earliest. So we are in the process of winding the programme down. It's obviously hugely disappointing, both for patients, residents, our staff, and particularly the team involved in developing the new hospital programme. It's going to be a significant challenge for us for the next 15 years. We think that it could cost us north of £300 million in additional backlog maintenance alone. And there'll be other costs such as the additional costs of heating and lighting a building that was built nearly 200 years ago in places. It also is going to present us some real challenges about meeting population needs and some of the wider goals that we've got for our community, including the net zero challenge, for just one example. We have been encouraged to submit some proposals for work to the new hospital team. That includes proposals around securing a site for the new hospital to try and lock the promise in that has been made within the programme, because there is an upside promise in the programme of funding for a new hospital for our residents in 2037. So the new hospital team are encouraging us to submit proposals that help us progress securing a site for the new hospital. We've also put in some proposals around really understanding the consequence of having to stay in our buildings up to 2040, and doing some work to understand what the life is on some of our buildings, and also what some of the alternative measures could be to just rebuilding them or to patching them, which could include moving some services out to our other sites and moving services out into the community and working in partnership with colleagues across health and social care. We're also looking at what we can do together to position our community well for decisions made in the future about new hospital funding. So we're exploring what a kind of health and social care or a health and life sciences task force around the new hospital could look like, and been having conversations with officials in Wokingham Council about their contribution to that. I think that's probably all I've got as an update. We have submitted those proposals. We're awaiting an outcome, and we're told that we may hear some news on that in the coming month. But really happy to take questions from the committee.
Thank you, Andrew. If I could just add to that Clive Jones, who's the Wokingham MP, saw someone from West Streeting's office last week about the hospital. Clive's a governor at the RBH and has been for quite some years now. We don't know what happened there, Andrew. I don't know if you've had any news from Clive.
I was with Clive at the meeting with the Minister of Health. It was a helpful meeting to be able to talk to the Minister about some of the challenges that we face as a result of the decision. However, I don't, and I think that we were encouraged with the schemes that we've still got that we're kind of asking about. But obviously the government has made, it's a really difficult decision here and isn't minded to overturn or revisit that decision at the present time. So we are having to look at what we can do within the parameters of what we've got.
Okay, thank you. Alison, was it you that had your hand up? No, sorry, Lou.
Sorry, could you just say a little bit more? You talked about the potential of progressing work to secure a site. How likely is that?
We're being given quite good encouragement about that. So within the letter that we had from the Minister on the 20th of January was an ask to talk to them about how we would progress a site. So that's quite a formal ask from the programme, and we've been given encouraging signs through the programme and also through some of the work of our local MPs, including Clive and also some of the Reading MPs, who are in their dialogue with the Department of Health and the new hospital programme team are also being told that there will be funds to support trusts like ours in securing sites over a much shorter time period than 2040.
No, I can see. Oh, Moses.
I'm just curious, how would the life cycle cost of maintaining the building as it is compare with the 2 billion earmarked for new construction? And then, is there any likely impact of the disbandment of NHS England on the program?
I don't know about the impact of NHS England on the new hospital team. They are part of NHS England, but they've also been given a programme to deliver. But from our perspective, it's very clear that they'll be focusing on the hospitals that have been put into earlier waves anyway. So I think that this probably doesn't affect us within that scheme. Your question was about the life cycle costs of the maternity building?
Yes, compared to the 2 billion over the time, 15-year delay.
I'd have to pick that up with our estates team and try and understand the specific costs of any one building. But the work that we've bid to do is to help us understand which buildings last for 24, last out to 2040, and the costs of replacing them either directly or by doing something different.
Good evening. Thank you. I was just worrying about the population demands growth, roughly how much, and also as the population's growing, we're also ageing with more health problems. So I can see that's a challenge. I just wondered if you got any ideas about roughly how much it's going to be, or not how much, but how many.
So when we were doing the modelling on the new hospital, we knew that if the current model of health and social care that we've got today continues out until 2040, then we would need a hospital that was 20% bigger than the current hospital that we've got. And that's predominantly driven through the ageing effect of the population. So even in our plans when we had a new hospital, we were going to be working really hard on the 3 shifts that the government set out in its 10-year in the Darcy review leading to the 10-year plan, around the shift to digital, the shift to working in partnership with community, and the shift towards prevention to improve the underlying health of the population. Without the new buildings, I think those shifts become actually even more important, and we need to be working to collectively about how we bring those about.
Thank you.
Any further questions? Adrian.
Yeah, one of the things, I'm on that, yeah. Thanks for the presentation. I was just wondering, we're going to spend 300-400 million maintenance until 2040 roughly, and an increase in utility costs. So it may be 400, it may be 500 million. If you got a loan from the Public Works Loan Board, how much interest would you pay on £2 billion in the next 13 years? Because if it's less than 400 or 500 million pounds interest, then if you could get a loan from the Public Loan Board, then you could just do it yourself.
Yeah, I'd have to explore the Public Works Loan Board. It's not something that we've particularly have had access to previously, Adrian, but I'm very happy to look at that. And that's one of the questions we've got to explore now is what other sources of capital are available together as a community to do some or all of the works that we might have planned.
That's a really encouraging answer, and I would urge you to try and do that. But I think this is a kind of capital project that central government should absolutely be doing, because it is in everybody's interest for this to happen, and it's in nobody's interest for us to spend a fortune looking after 200-year-old buildings with lots of maintenance issues. So if you could come back at some point, Andrew, and try and bring forward some kind of conclusions to other sources of funding, that will be really helpful. Yeah. Thank you.
Good. Happy to do that.
Any further questions? No. Thank you very much, Andrew. We're sorry it's not such good news as we'd hoped for, and perhaps the Public Works and Loan Boards may be able to help. Certainly it's been very successful for some local town and parish councils who've done very well out of it.
Thanks so much to the committee for giving us the time and for your support and for it, both on an individual and collective level. And I know that we'll be back looking for that dialogue and conversation again. But thank you very much.
I'm sure we'll see you again. Thank you. Right, we're now going on to item 44, community pharmacy, on page 17 of the agenda papers. I'm not quite sure who's presenting this.
Julie Dandridge.
Oh, Julie,
hello, Chair.
Yeah, hello. I can see you now. You've popped up on the screen.
I have. I was waiting quietly in the background, and I am here with my colleague Hugh O'Keefe, who's going to do the dental, so the dental paper. But if we can do the community pharmacy one first, and I will introduce myself. I am Julie Dandridge. I am the Associate Director for Pharmacy, Optometry and Dentistry, working in the Integrated Care Board, and have a responsibility for ensuring that we have community pharmacy services, dental services and optom services for our population. So, Chair, I've shared a paper which gives an oversight of where we are in terms of community pharmacy. Just to pull out a few highlights for the committee. Firstly, we've seen the opening of Winnersh Pharmacy, which I think has been really well received following the closure of the Lloyd's in the Sainsbury's, and actually the owner is really wants to be that pillar of community and is doing a lot to support things. So I think that's really positive for the Wokingham population. In terms of Pharmacy First, I think I was here about this time last year where we were just launching it, and we have seen the numbers continue to grow over the year, with community pharmacy providing services to the population really well. There's quite a lot of confusion around Pharmacy First and exactly what it includes, and it includes urgent medicine supply, minor illness referrals and clinical pathway consultations at this point in time. I think going forward it's likely to pick up the blood pressure monitoring and also the oral contraception service. But this report just relates to the urgent medicine supply, the minor illness referrals and clinical pathway. I think we've seen the numbers continue to grow over time, and community pharmacies in sort of embed that service. We're finding that most people access Pharmacy First directly, and by direct approach of the community pharmacist for the treatment of one of those 7 conditions. Although there is some small referral from general practice. We're monitoring what's happening and what prescriptions are being given. Interestingly, you can see from point 17 that actually Wokingham is probably doing more pharmacy first consultations per 100 patients than across the rest of the BOB footprint. But what is noticeable also is that most of those are for urgent medicine supply, and we would normally expect someone to get an urgent medicine supply if they run out or haven't been able to get their prescription. They ring up 111 or apply online, and they get sent to a pharmacy. So I think that is slightly out of kilter with the ratios that we see for other places. As is norm, you can see that most common condition treated is an uncomplicated urinary tract infection, and I think we're now starting to see that rise. Obviously, in over the winter, it was more the sore throats as we go forward with that. We have recruited some PCN community pharmacy leads, and one for each of our PCNs, and their job is really to strengthen that link between the GP practice and the community pharmacy to embed some of these services across the PCN. We shouldn't forget the other services that community pharmacy offer, especially the hypertension case finding. You will remember that from our primary care strategy, cardiovascular disease prevention is a great was one of our 3 priorities, and community pharmacy have been offering that service. And incidentally, I don't know if Hugh will mention it, but they have been supporting our dental practices who are piloting doing it too. So it's a great joined up primary care approach. One of the things that we want to work on over the next 6 months is promoting the pharmacy contraception service. So community pharmacists can do repeat pill prescriptions and even initiate prescriptions. And for the cohort of patients that require these services, easy access, I'm sure, will be beneficial rather than trying to get a doctor's appointment. So we're going to promote that over the next 6 months with the help of our PCN leads. There's a few other services that are mentioned in here, which help. I know that I saw that you had Andy on earlier, but one of the things we're in community pharmacy can pick up is review of discharge medication. We know that side effects are a common reason why people are admitted to the acute hospital. So a review by a community pharmacist can help with that. And Hugh and the team are working closely with the RBH on that. We've talked before about the patient survey and patient experience. The NHS England are now producing something called health insight data, which takes a period of time and surveys a certain number of patients in terms of their access to primary care services. And I think this is something that we will be looking at going forward to see where there is satisfaction or not satisfaction. Unfortunately, it's only done at BOB level, so it's very difficult to look at it any further and to work down. As in next steps, as an ICB and as an ICS, we're looking at the neighbourhood health service, and I think having community pharmacy embedded in that or in the integrated neighbourhood teams is going to be important, and we need to work to make sure that they are all integrated as part of the service. I've talked a bit about where we are with oral contraceptive services, and the other one we're going to further promote is our minor ailment scheme, which provides some patients who are on low income access to free over-the-counter medicines for some minor ailments. So those are things like head lice treatment to stop patients going to the GP for a prescription and being able to get them free of charge from the community pharmacy. It's quite a niche service, but is very valid in some areas of our footprint. I have included some specific data for each of our health and wellbeing boards, and Wokingham is at the end, and I'd be very happy to take any questions, Chair.
Thank you, Julie. That's a very nice report to read from you, because there's an awful lot of positive things in it, probably especially the minor ailment scheme for those of us that work with people who are living in poverty and children living in poverty. Do we have any questions, Lou? Then Alison.
Yeah, no, thank you. I was quite interested in just understanding a little bit more about how the figures for the Pharmacy First fit in terms of sort of context and targets and what you're expecting. So is that I mean, did you have targets for the number of consultations you were hoping to see in a certain time frame? Have you seen any impact on it in terms of freeing up GP appointments for other things?
Yes, thank you for that question. We were there were some targets for Pharmacy First in the PCARP, the Primary Care Access Recovery Plan, which we have been working to, and which we have met. There was a little bit of a dip in August, September, and I think that was probably around around holidays, but we have met that. As the question around have we managed to release GP appointments, I think that's a really difficult one to measure, because if you free up a GP appointment, it gets filled again really quickly. But we are looking really closely at our GP access to see how we can support, how we can use community pharmacy to support access to GP services for the patients. And I work very closely with the general practice team within the ICB. So yeah, it's a good question. I think it's very difficult to quantify. You may remember we did the community pharmacy consultation service, and that had a few numbers associated with it, which allowed us to state how much GP time, but actually how much true GP time, I think it's difficult to say.
Can I ask a follow-up?
Yeah, please.
So, sorry, a bit of a data person, so I apologise. I was just wondering, particularly when I was looking at the numbers for urinary tract infections, do you have sort of further data, how many were actually given a prescription, how many did end up back in the GP surgery? Do you know any of that level of data?
We do have a bit of data that shows how many patients couldn't be treated by the pharmacist and had to go back. So we do have some of that, and I'm happy to share some of that information with the committee. The other thing we are closely monitoring is the number of prescriptions that are issued, and it's and also whether we are seeing an increase in antibiotic prescribing, because obviously there was a fear that we would just get more people presenting, more people with antibiotics, but early look at that doesn't show that to be the case. I think the early data shows that something for for things like UTI and for things like UTI, it's about 70% of the contacts get a prescription, which is probably what you get in general practice.
Sorry, just one more small question, just around levels of awareness, and if you're sort of being able to measure sort of levels of awareness in the community about Pharmacy First, so that people know they can, you know, go to a pharmacy rather than call the GP. Do you have any information on that?
I can see we've got Alice from Health Watch on the call, and I know they've been doing some work to look at to look at awareness. I think there's way more that we can do. I think it's not just about awareness. Sorry, Alice, to put you on the spot. I think it's not just about awareness. I think it's about changing culture and getting the population to recognise the health services that pharmacy can provide, and it's not just about getting your prescription dispensed. It's about some of those clinical services, and I think that's the whole shift that we need to do to really support the whole agenda and the whole left shift agenda.
Sorry, Alice, did you hear me? Are you able to answer that question quickly?
Yeah, I am. I'm just to share with you that what was shared is true. I think there's a lot more work needs to be done, and it incorporates with the GP access, the new way of working as well. So there's a lot of work being done at the ICB level to try and make sure that the community is aware of the new way of working. Thank you, Chair.
Thank you.
Alison.
Thank you. I'm looking at page 32 of our agenda, which is page 16 of your report, Julie. The map for Wokingham showing where the pharmacies are. I remember when we previously had a presentation about pharmacies, and we had a map, and we were told about there's the consideration about everybody should have a pharmacy within a certain radius of their home. I can't remember what that was. But looking at the map, I see we still have the problem that people in the Arborfield, Barkham, you know, are in a big area, not near any pharmacies, and there are also people who have limited access to regular bus services. And I just wondered if you could expand a little bit on what the ambition is, that, you know, everybody should be within, I don't know, 4 miles of a pharmacy, and whether there is consideration to the Arborfield Barkham area having a pharmacy, because there is a lot of house building and more planned development there.
Thank you, Alison, for that question, which is hugely timely, because we are led by the Public Health Department reviewing our pharmaceutical needs assessments, which looks at where there might be gaps in provision. New pharmacies are really tightly controlled by new market entry, and effectively you need to agree. It needs to be written in the pharmaceutical needs assessment, which we are currently reviewing in order for someone else to apply easily to go into that into that space. And that work is absolutely happening as we speak, led by your Public Health Department with our input, and will be signed off by the Health and Wellbeing Board, the local Health and Wellbeing Board. But it's something that we look at all the time. We think about new population growth and where services come from. People can go to any pharmacy, so you do need quite a considerable number of people to make a pharmacy viable. But I'm sure it's something that the local PNA group, Pharmaceutical Needs Assessment Group, will consider.
Thank you.
Sorry, can I ask a second question? On page 26 of our agenda, page 10 of your presentation, the minor ailment scheme, which, you know, I'm very pleased to hear about, because over-the-counter medicines, are still out of the reach of low-income families, and going to the GPs to get the prescription is not an efficient way of doing it. But the final sentence said we would continue to promote this in areas of need. Now, Wokingham is, as we're always considered to be a borough that's very prosperous, but we do have areas of deprivation. We have children and families living in poverty. So I would have liked this to say we continue to promote this scheme to all those in need, so that all of our families here are aware of it, and that it's being promoted by all of our local GPs to families that would benefit. So will that be happening across Wokingham Borough?
We have, so we've had this scheme in place for probably just over a year now, across the Bob footprint, and we found that where it gets, and we did make it open to every pharmacy to sign up to it across the patch, but where it gets used is in those areas of deprivation. But we're really happy to look at it and promote it locally across the Wokingham Borough if members feel that would be beneficial. And as you say, it helps with access. It helps with a number of things. So I'd be very happy to take that back and look at that for you.
Absolutely. I think every councillor knows that within their ward, there are roads, there are small areas where there are families who would really benefit from this. So I don't think there are, areas of deprivation in Bob. I think every single area has families who need this.
Thank you for that.
Okay. I was interested to read about the distance selling pharmacy that's opened up. Is that presumably...
Can't hear you.
I was interested to read about the distance selling pharmacy that's opened up. Presumably, is that for repeat prescriptions and to help alleviate the amount of work that they're doing in the normal pharmacies?
Yes, so pharmacies can apply to be distance selling pharmacies, and I think it's almost an easier way to set up a pharmacy. If you want to do a shop front that patients can access, then you need to adhere to the market entry regulations, whereas a distance selling pharmacy could theoretically set up anywhere and offer services to a much wider, it's not geographically based, could offer them anywhere. They tend to see more prescriptions going in and out, and that's how they do the volume to get the numbers. But they can't offer advice on-site advice or things like that. They have to do it indirectly, so to speak. So we have seen a number of distance selling pharmacies set up, but we've also, you will see on my page 3, sorry, I haven't got your report on number 11, that actually two of the 7 pharmacies that have actually closed are distance selling, because actually they need the numbers of prescriptions to get the return on investment. So I think they serve a purpose for some people, but don't really do the high street clinical advice.
Are these repeat prescriptions, I was wondering, because I noticed that they can telephone a patient to counsel them on the medicine's correct use. And presumably if people have other medication that changes and so on, that can have an effect. And we all know, I mean, I don't often take medicine, but you can't read the instructions, they're too small. So it just sort of raises a little bit of alarm, or the risk factor of people not understanding how to use the medicine, or it's sort of being just the odd question asked. So I just wondered how that was managed or monitored.
Yeah. In the main, they are for repeat prescriptions because they obviously have a lead time because the prescription often comes in the post. They would be dispensed and then it comes in the post. But the pharmacist has a duty to make contact with the patient where they feel that they might need some more advice or when where things have changed. So the patient should be able to access the same thing, but just not in a face-to-face manner. Interestingly, distance selling pharmacies can still do pharmacy first, all except the earache because they can't examine. But that hasn't really taken off because actually you need the patient pharmacist interaction.
Okay, thank you.
Any further questions? Moses?
Thank you, Chair. There's a lot of controversy in the news about physician associates acting as doctors. So I've used Pharmacy First. I was just wondering, is there any feedback to show any evidence of misdiagnosis? Because I won't say my personal experience was 50%.
So the question is around community pharmacies and misdiagnosis.
Yes, is there a feedback from patients who use Pharmacy First?
Yeah, we haven't had that feedback. The feedback that we did get at the beginning was I went to the pharmacy first to get my to have my UTI treated, and actually they said they couldn't give me anything, and the reason for that was because it didn't fulfill the criteria that the community pharmacy can work under. The community pharmacy restrictions in terms of what they can give and to who are quite strict, and so that is. Look, I'm not going to say that there's probably never been a misdiagnosis or a prescription given incorrectly because I haven't got any facts. But I think the pharmacist as a clinician has very strict criteria and pathways that they need to follow in order to give a prescription and to offer treatment. So it is really tightly controlled, and I know that nationally they are doing a review of the whole scheme just to provide that extra assurance to patients that this is clinically safe.
I'm trying not to be too specific here,
Yes.
because what could appear like minor, for example, if what looks like a fungal infection, could actually be signs of things underlying. And if you go to pharmacy, they may just give you a cream. But when you go to the GP begins to tell you a bit more.
Yes, but pharmacies will have red flags, so they will so if I don't know if the fungal infection has been there for 3 weeks, then the pharmacist probably wouldn't treat it. They would say go to the doctor. If the fungal infection was in someone who was immunocompromised, couldn't fight infections, they would probably not treat it and say, well, they shouldn't treat it. They should refer the patient. So I think there are some criteria that pharmacists would do, and I think anybody would any pharmacist would say actually we'll give you this, but if it doesn't clear up, you'll need to go and see your GP. So there are some safety netting in there.
So, okay, thank you. This is not a question, just a suggestion following on from what Lou said. If you wanted to see how Pharmacy First is helping the efficiency of the GP practice, you could actually see how these figures compare to what it was before you introduce the Pharmacy First. That will tell you, because this ordinarily would have gone to the GP, but now they don't have to.
Yeah. Yes, and we've yes, thank you for that. And we've been looking at the number of prescriptions, for example, for penicillin for sore throats to see has it increased hugely? So are the community pharmacies seeing an unmet need? Are they prescribing where perhaps a GP wouldn't prescribe? So we are doing that bit of work to understand that.
Thank you. Any further questions, or Adrian?
I would like to say I think because the GPs are so hard pressed, I think this is a very good initiative. And actually, we as a family, because I've been on this committee, we've used this quite a number of times. But I must say that some of the criteria are really, really weird. So, you know, my daughter had an earache. She could be treated. I had an earache, but I couldn't be treated because I was over 18. And there are other ones where if you're over 64, you can't get things, but if you're under 64, you can get things. And really strange points, which don't seem to make any sense whatsoever to me. So I'm very pleased that you're saying they're going to review the scheme and hopefully, you know, from my perspective, get rid of some of these weird anomalies. You know, when a pharmacist is talking to somebody in front of them, they can surely see if the person's in agony and about to keel over. You know, if I've got earache, you know, and I'm standing there, it's not a major issue because my head's not blowing up. So I was really annoyed that I couldn't get a simple medication for, you know, a straightforward earache. But I look forward to the review. Thank you for your information.
Yeah, thank you for that feedback. And I think the criteria have been as frustrating for some of our community pharmacists as they have for patients. But they're nationally determined, and I think, you know, they had to start small because otherwise there would be, I think Moses mentioned, you know, some of the concerns. Actually, we had to start small. So let's hope that that they see it right to grow it, and that community pharmacy can offer more on the high street.
Nagy.
Hiya. Currently, or majority of the community pharmacies close about 6 p.m. Is there a provision to improve those hours, or emergency ones if possible? Thank you.
Thank you. So this is about how patients can access medicines once a pharmacy is closed for the evening. We do have some pharmacies that are open longer hours. Those are the 100-hour pharmacy. I was just trying to look at my list to see which ones are in Wokingham. They used to be open for 100 hours, so used to open into the evening, and on Saturdays and Sundays often used to close at midnight. But actually, they found that they weren't really used. They weren't really needed into that length of time, and a change in a change in regulations have meant that they now don't have to open for the 100 hours anymore, and we have seen them sort of close at 9 or 10 o'clock at night. Access to medicines out of hours is not as easy as it could be, but there are ways round it and to do it. But I think I have had raised with me before access to medication out of hours, and the best thing to do is to go through 111, who can advise how to access the medicine once all the pharmacies are closed.
Thank you. Thank you very much for all of that information. It was very thorough, and it'd be nice to have a follow-up at some stage. Hugh, we're over to dentistry now, equally as unpleasant as being ill.
Thank you, Chair. Yes, this is an update report on recovery from the pandemic. So I think it's about the third one we've submitted to you. So the key headlines are that dental access is continuing to improve, but challenges remain, particularly for people who've not attended a local dentist in recent years. We are commissioning and delivering more activity, which is increasing capacity in the system. So Wokingham as an example, is up by about 10,000 units this year compared to last. We've still got a situation with practices leaving the NHS or reducing their commitment. So since 2021, 19 practices have handed back their contracts, 11 have reduced them. That is about 6% of the capacity that's been lost in that time. And 2 actually left in Wokingham in 24/5. So Beanoak and the Gallery Dental practice in Lower Early handed back their contracts. We're going through a process now to recommission that activity that's been lost. And about half of that has now been recovered in terms of local practices. There's 3 practices in Wokingham through this arrangement are delivering more activity in Twyford, Woodley and Wokingham. The other half of this activity we're commissioning through procurement of new practices, and that is focused on Oxfordshire, which has been much more significantly impacted by the contract handbacks compared to other parts of the patch. There are national and local actions being taken to address the challenges. So contract changes were made in 2022 and again in 2024. A minimum unit price, the minute UDA price as it's known, was introduced in 2022 of £23, and that was increased to a minimum of £28 in 2024. There's 50 practices in Bob saw an increase in their price in terms of the total contract value as a result of that change. We're able now to pay for more performance with the dental practices. They have cash limited contracts to deliver activity targets. We can pay for more over performance than we used to be able to, now up to 110% of contract value. And this year, there's 7 practices in Wokingham advising of plans to overperform with 13,500 units of dental activity, which is about 7.5% of the total we commissioned for the patch. Golden Hellos have been introduced to support recruitment in these hard to recruit areas, so particularly in the more rural areas. 2 practices have taken up that offer so far. The flexible commissioning scheme, which I think we've talked about here before, is just about to enter its 3rd year. We started in June 23. This scheme is for patients who have had particular challenges accessing dental care. There's 3 practices taking part in the scheme in Wokingham, and since the scheme started across Bob, there's been about 26,000 patients have been seen within these practices. The government manifesto set out an ambition for additional urgent dental appointments, so we've started to implement that. That was started in January 25, and we will roll out that scheme in 25-26. At the moment, we've got 4 practices in Wokingham taking part in that scheme. In terms of oral health improvement, the new practices that are going to open in Oxfordshire will have a flexible element to that contract, which will focus on children's oral health improvement. So trying to use some of the clauses within the contract that could enable us to do that with new practices starting up. We're investing into waiting list initiatives where we have got challenges around access and waiting times. That's particularly the community dental service and community-based specialist oral surgery. And the last thing just to mention is we are being advised of significant contract changes in early 2026. This will increase the focus on prevention, and the additional urgent appointments is a sort of first stage of bringing in a new contract from early 26. Thank you.
Thank you again. Some good news and some developments in that report, but I'm sure we have some questions. Caroline.
I think mine's quite a simplistic one. Seeing there's a massive amount of people who haven't been to the dentist for quite some time, is there a backlog of dental work that needs to be caught up? Because I know if I haven't been for a while, my dentist tells me off, and I always need more treatment. Sorry.
Yeah, we dread that being told off by the dentist, don't we? I mean, that's what a lot of the flexible commissioning scheme is about, because this backlog has built up because the practices back in 2020 had to close for 3 months completely. That was all NHS and private. And then the NHS service operated at reduced capacity for 2 years. So yes, there has been a backlog that's built up. And then when the patients have come back into this system, they've got higher treatment needs. And one of the discussions that we've had with the profession locally is trying to create sort of time within their service to meet those treatment needs as they're presenting. And that's one of the bits of the thinking behind flexible commissioning. Often if people are coming into the system, they haven't been to the dentist for a period of time, they're likely to have higher treatment needs. And this scheme enables them to have a bit more time to be seen by the dentist, and reduces the pressure that puts on the dentist in terms of having to get through all these units of dental activity each year. So it's trying to develop a system that supports the patients and their practices.
Thank you.
Any further questions? It looks like you've got off quite lightly, Hugh.
Oh, no, Alice is there.
Oh, all the hands went up then. I'm really sorry. Lou.
Okay, on page 45, section 6, other dental services, you've provided information about the services commissioned for Buckinghamshire. Would you be able to tell us about Wokingham?
Is this section 6 reference to the table on section 6? Is that what we're talking about?
I can't hear you. Afraid you're fading out.
Oh, sorry. Can you hear me now?
Mm.
I'm just checking in that you're looking at paragraph 6, other dental services, the table there.
Yes.
Yes. So these services are across Bob. So the community dental service provider in Berkshire West is the Berkshire Healthcare NHS Foundation Trust, and they also provide the unscheduled dental care services alongside a couple of other dental practices in our patch. Then there's the hospital services there, the OMFS as they're known, and the Royal Berkshire one is the one in our patch. And just for information, the hospitals there act as a group for that service. So the hub hospital, they're all employed by Oxford University Hospitals. That acts as the hub. They see patients as inpatients there, and then a number of them then work in other hospitals, but they're all linked together. And then we've got these community-based tier 2 oral surgery and restorative services with locations across the patch. So we have those services in Berkshire West as well.
And the tier 2 oral surgery and restorative, do Roderick's Dental Limited provide for the residents of Wokingham?
Yes, they do. It's a referral service as per the other ones on that list.
Okay, so possibly it was just a bit misleading, but it said that it's the services for Buckinghamshire detailed below.
Oh, sorry. Yes, there's a typo there, isn't there? Yeah, sorry. Yes, I'm seeing your point now. Yeah, it should say Bob. Yeah, sorry.
Okay. Thank you.
Thank you. Lou.
Hi. So I just wanted to ask about targets again. So in the summary on page 46, you talk about the levels of provision now moving back towards pre-pandemic levels. But if I was to be slightly critical, I might suggest that the access to NHS dentistry prior to the pandemic wasn't exactly fantastic. So is there a longer term aim?
When the 2006 contract came out, the dental access in our patch in terms of the population was about 43%. So there was a lot of unhappiness with the 92 contract. Lots of dentists left the NHS at that point, and there was a big collapse in NHS access in the 90s and the noughties. So then there was a government-coordinated dental access programme, which started being implemented in about 2008. A number of new practices were then opened. So we saw new ones in this area in Finchampstead, in Winnersh, one opened in Wokingham. And that pushed the access levels then up to about 52%, about 250,000 increase in the numbers attending. And that then sort of collapsed really then as a result of the pandemic. Now, part of that is part of the problem we've had with this is the nature of the units of dental activity system. It's an entirely activity-based contract. So that's why we've started to see some of these changes coming into the contract, and they're bringing in new changes from 26 as well, because the contract proved to be pretty inflexible once we saw this impact of the pandemic, and then that also then has serious implications for the amount of patient charge revenue that's being collected. Our budgets are based on an assumption of level of collection, so there has been some oscillation in the access into NHS services. Broadly across the country, dental access has probably never been more than somewhere in the 50%. So, and some of that is really just designed to the way patients access services. So there is a proportion of the population goes privately, and there are some that don't go at all, and will only go when they have dental pain. So, you know, our goal is really to try to get back to where we were, which we had spent about 12 years trying to build up to that place. We think there is that demand in the population. It's just how we can get the services to you know, be fully restored to where they were pre-pandemic. But that is significantly challenging in terms of the impact the pandemic has had on the oral health of the population.
Thank you, Hugh. Sienna.
There's been a lot reported over the last few years, really, about the lack of NHS dentists. And just a couple of days ago, it was reported that 30,000 children were hospitalised last year for wholly preventable decay. And I'm just wondering why we aren't targeting and preventing and putting things in place for our children. And I think when I was back at school, every child had a dental appointment at school, or maybe it's just because I lived in remote schools, but the dentist came to the school. So why aren't we doing things like this to protect our children? Children are arriving at school with no teeth, apparently. So why aren't we doing things in preschool? In places, I can't remember whether it was Finland or Norway, it was one of the Nordic countries, where every child after lunch has to clean their teeth. It's part of the school meals. And not only do they clean their teeth, they have something, I don't know what it was, that they chew, and every child has one that protects their teeth. And there are no fillings in the country. The children that go to school have got good, perfect teeth. Why aren't we hitting it earlier?
Well, I think that's right. I mean, the evidence is the earlier children start to go to the dentist, the better. There was a national programme being run pre-pandemic called Dental Check by One, which is trying to get children in, even before they got their teeth, in to see the dentist. We were part of a national Starting Well programme that ran prior to the pandemic, which was focusing on the 13 local authorities with the worst oral health in the country, and at that point Slough was part of our patch, so we were part of that, and we actually then locally rolled that scheme out to High Wycombe and to Oxford. You know, there is a lot of support, I think, amongst the dental practices, dental community generally, to do this. I think the pandemic then has had a massive effect in terms of just trying to recover to where we were. What we're doing with the new practices in Oxfordshire is essentially a starting well model with those contracts. So we will start to bring in that sort of early intervention service with those practices. And because they're new practices, we've got that ability through the procurement to use some contractual levers to get that to happen. The flexible commissioning scheme, we're trying to look at how we might evolve this in the next little while. If we can get some greater stability around the access, and so we're not sort of losing dental practices at the rate we have, it is slowing down, then can we start to use flexible commission to focus more on children particularly and oral health. And the other thing that's coming in with the new changes in 26, that what we're seeing is there's quite a bit being talked about then in terms of interventions that are around children's oral health, which is to do with things like fluoride varnishing and fissure sealants, so that they do start to use the contract nationally to focus in on this. I think this is a really major issue. There's a lot of information to say there's too many children going in to have their teeth extracted. We should be doing more on that more quickly. That does need joint work with local authorities in terms of how that's done. The local authority actually leads on commissioning oral health. There has also just been an announcement about from the health minister about supervised toothbrushing and that being rolled out. So we're just waiting to see more information about that. And that's picking up on your point about brushing teeth after lunch at school. We're waiting to see which local authorities are going to receive funding for that. So, I mean, this is you've got to be an area of focus in the next little while.
Thank you, Hugh. Any further questions, Nagi?
Before I ask my question, I let Alison come in. She's patiently waiting, so yeah.
Thank you so much, Councillor. Thank you, Chair. Hugh, one of the things I wanted to find out on your flexi commissioning service, the dental service, does it include care homes?
It's going to from April.
Oh, okay.
Yeah, we're going to send some comms out about that. So we're just updating the specification for it. So we're adding in residents of care homes who can get into the surgery, we should say. So they need to be able to get into the surgery, and also in terms of support to the urgent dental care appointments for those patients who need further appointments, non-urgent appointments for stabilisation of their oral health, they can go to flexible commissioning practices as well.
Just to suggest, is a suggestion in the sense that I do think that a little bit more comms about the flexible commissioning service is needed. It's an ad hoc kind of thing. I do think that it's needed because I don't think many people are aware that who is entitled to it.
Yeah, I agree. Yeah.
Thank you, Chair.
Thank you, Alice. Jyoti.
Thank you. I just wanted to update the committee on the supervised toothbrushing that was just mentioned by Hugh. I have received a letter from the Department of Health via OHID confirming which authorities will get some additional funding for supervised toothbrushing, and I'm afraid that Wokingham are one of only 6 areas that will not be receiving that money. I am writing with 2 other of my colleagues in the region who have also not got the money to make the case that we do actually need the money, that our pockets of hidden deprivation, there's high need in terms of SEND, etc. So I am writing back to make the case for Wokingham.
Thank you. Yes, I mean, we all know that, but we're always treated as the no money thing, but we're not all wealthy. Nagi.
No, I'm just recovering from that one.
Okay.
Yeah, so Hugh, the report is good. I think majority of the things are looking positive and optimistic for future. But I think I feel the demand is too high, and these measures might not be sufficient because, as an example, last month, I myself rang about 4 different dental practices, and the private ones, they're happy to take me in with open arms, but whereas the other ones which provide these NHS dental, there are very few of them, and even if they are accepting, the appointments are, I mean, yeah, I couldn't get one this month, so I have to do early April. So yeah, with increased demand and increased housing targets and population, how are we going to overcome this one? That is the first question. Yeah.
Yes, I agree on that that demand issue, and that's what we've been trying to do with our sort of contracts locally, to either sort of recommission what's been lost, and you know, we should say that the amount of capacity that's been lost is significant. So it has been a major undertaking to try to get that restored. Again, I think we're making good progress on that. And one of the things to say, there's a little bit of headroom in the contracts that we've got in Wokingham at the moment. So practices are delivering somewhere just over 90%. So there's a bit more that can be done through those contracts in terms of delivering all the units that are available. There is something being brought in now nationally in terms of an allowance on behalf of the commissioners to rebase contracts if they persistently underdeliver, and then we can look at reuse, making sure the resource we get is used as fully as possible. I think that sort of the medium term with the housing is the sort of next thing on the list for us, really. If we can now say we think we're moving back to where we were in terms of those levels commissioned, and we're making good headway now in Oxfordshire. If we get these up and running by the end of the year, we will be back to pre-pandemic levels in terms of the activity commissioning of what we're commissioning. But yeah, we then do start having to look at, where's that population growing. There's quite a bit we can do with the contracts we have to try to respond to that. So, and there are plenty of local practices that would look to take on more NHS work. So we can do that with our local practices in the libraries. We haven't necessarily got to go out and market test and bring in new provision all the time.
The answer is, once you get a dentist, you almost live there. You keep going so that he remembers you, and you keep going and going and going.
Thanks, Hugh. That's helpful. I have another question. So even with very good care and visiting the dentist 3 to 6 months, there's still sometimes requirement for emergency dental services. So so I was speaking to one of the residents, and they struggled a lot to find emergency dental care. Is there anything to improve that facility?
Well, that's what's being brought in now through this government manifesto pledge. People might be aware of the 700,000 additional dental appointments. So we're all being set targets in terms of the numbers we've got to do. So we've just started this scheme in January just to sort of test it out. That's over and above what we're commissioning at the moment. So, and then we're now working through running the scheme in 25-26, and we'll be doing some communication about that. It's sort of something you can either access directly or through NHS 111, but we'll be getting more information out there about how patients can access those practices.
Thank you. Yeah.
Thank you, Hugh. Are we happy now to move on to the next item? Are there any further questions? Can we go on to agenda item 46, which is the update from Health Watch? Alice, over to you, please.
Thank you, Chair. I have sent you all an activity about all the activities that Health Watch has been up to. But one of the things that I quite like an awareness to is our GP access report that is still active. I have written to the Health and Wellbeing Board asking for their support because our concern is there's still an ongoing concern that has taken time to be addressed. And so, based on the health and well-being strategy, I do think this needs to be looked into, because we are still despite the fact that this report is over a year old, we are still having the same feedback that clients are not getting the appointments, or they're struggling to see the practitioners. So that is one of the GP. We are still doing dentistry. We are still Hugh has showcased sharing with what that's happening. But we are still hearing that there are challenges in Wokingham about getting dentists. And Pharmacy First is already, you've heard, but we are looking at it in such a way that we want to see whether really do the public really think it's a good service. And I have alluded to you all last meeting about the Women's Health Hub, and that continues to be a discussion in the Berkshire West. And Jyoti is very involved in it, whereby, again, we've been told there's no money, despite the fact that we've asked, there's no money, and we've been told to look for money locally. So there's going to be a joint letter going to the Integrated Care Board to address this. But this is so unfair, because this is another inequalities for women in Berkshire West, because there is a service in Oxfordshire and Buckinghamshire. It seems like and everything is on that side, but we need to fight a little bit more for our cohorts here. I think the activities that I've shared in the previous report is the same. So, if there's any questions, I'm happy to answer them.
Adrian, could you just hold on a minute and I'll ask one first. On the Women Health Hub, you've talked about an event called Women's Hour, but you've not given us any more details. Have you got a date?
Not yet, because I'm looking for funding at the moment to see whether I can. But and also different ways of trying to get feedback from the women. So if I can't get funding for the Women's Hour, what I want to try and do is do surveys and do focus groups in small areas of getting the vulnerable group women to speak. But yeah, it is. I'm hoping that I might get some funding with this new financial year to do something in June, possibly.
If it's between meetings for the HOSC, could you let us know?
Yeah.
Please. Thanks,
okay,
Alice.
Yeah.
Adrian.
Yeah, I think, what we've been hearing tonight is, Wokingham falls off the radar for everything. And this is not a good enough answer. When I went to the last Bob HOSC meeting, the chief exec said the reason for Bob existing was to equalise things. And if we are going to perpetuate different services for Oxfordshire and Buckinghamshire to West Berkshire and Wokingham, different levels of funding, whatever it is, I need to push this question back to Nick and say, a year ago you stood up and said we were going to equalise things, and X, Y, and Z proved that you are not equalising things, and that the differentiation with Oxfordshire and Buckinghamshire is continuing. So, I would like Public Health and Health Watch to work together to work out every item where we are disadvantaged, stick that in a paper, stick that in an email, and I will take that information to the next Bob Hoss meeting, and I will ask the Chief Exec what he's going to do about these things. Because I mean, I'm just, you know, I'm astonished. Yeah, I know you've said this before, Alice, and, you know, everybody on this committee is very unhappy with this. And we have to raise the profile of this. We have to ask questions to the Chief Exec. So I would appreciate Public Health and yourself working together and get a list or something with everything that's different between the different areas. And then I will ask these questions. Thank you.
Thank you, Adrian. Josie, did you want to comment on that from Public Health?
Just to say that the dental issue isn't, the supervised toothbrushing isn't to do with the ICB, it's Department of Health directly via OHID, Office for Health Improvement and Disparities.
Are there any other areas of inequality you've come across in your very short time here?
In terms of Bob, just this Women's Health Hub issue, I haven't come across any. There may well be others, but not that I'm aware of.
Don't have any other questions for Alice?
Hello again, Alice, and thank you for everything you and Healthwatch are doing. It's fantastic the way that, you know, you're taking that lead on interacting and listening to our residents and sharing those insights with us. Could you tell me some more about the NHS eligibility to treatment that you're doing an event about? Because I mean, you know, when we're abroad and we have health issues, you know, we all make sure we have insurance that pays for them, so that people who come here, it's quite right that the NHS immediately treats and helps anybody who's unwell, but that should then be recouped from their insurance. I'm not sure that has been happening, so could you tell me a little bit more about these changes, please?
So the whole I think about the topic that about NHS eligibility treatment started with actually a counsellor in West Berkshire who was being billed by Royal Berkshire Hospital for treatment, though he is a UK citizen. So that was the shock of it all, why they billed him. And then it came to our attention, and then so we took it on to find out from Royal Berkshire Hospital to say, why is this happening? And then we found out later on that there were little children being billed. So that the question was, are they being billed because a lot of them were from the diverse communities? Because it was this counsellor thinks that it was because of his name. That's why he was being billed. So Royal Berkshire Hospital has done a lot of work trying to make their website a lot more friendly and also clearer a messaging about who will be billed. However, the only issue that we have at the moment is when you go onto their website, it's not very visible of where it is. So people don't really understand who are entitled to it and who are not. So we've asked Royal Berkshire Hospital, and I don't think it's Royal Berkshire Hospital is the only hospital. Most hospitals have this issue. They are not very clear about the ordinarily resident, those who are entitled to treatment and those who are not. And that's a Home Office issue, to be honest. But I do think people are not aware that there are some treatments that some people are not entitled to. They are only entitled to emergency treatment and possibly maternity. But the rest of them, after that, they have to pay if they are here. And I do think that messaging is not clear to the public in itself. So then there's going to be a lot of work. So Royal Berkshire Hospital's done work on their website, and they're planning to put a fact sheet on that website so that people can print them out and share with as many people as possible. But we are advocating that there's going to be clear messaging about this so that people don't misunderstand.
Adrian.
Yeah, this is for public health, Jyoti. Sorry, I'm not sure if that's the right pronunciation of your name.
Jyoti, but
Jyoti.
I don't get offended, don't worry.
Thanks. So when we had the coroner's report last, this sounds like a death, doesn't it? We had the coroner's report to us last year, and Berkshire is an outlier in terms of the number of non-invasive autopsies carried out. The reason given verbally at that meeting was insufficient scanning capacity at RBH. So if you look at Berkshire compared to, we are an outlier in the UK, not just in Oxfordshire and Buckinghamshire, but we are the worst in the UK, and considerably worse than anybody else. And one of the questions that has been raised from the Muslim community, who have very specific guidelines, I don't know what to say, in terms of, what they want to do if a person dies, in terms of timeliness and keeping the body whole and all these kinds of things. And what we wanted to get out of the coroner's service was an agreement that if anybody specifically requested a non-invasive autopsy, they could get one, and they couldn't give us that guarantee. So I don't want to call this racist, but it seems to be there is a difference if you're in Berkshire compared to other places in the country, and your chances of getting a non-invasive autopsy, an invasive autopsy, are much higher in Berkshire than anywhere else. So I actually want to, as part of our work programme, get the coroners back in and see if they've sharpened their pencil or if they're still the worst in the country. But in addition, I would like this to be included on the topic of things where Berkshire is worse than anywhere else, because, I want to bottom this issue out, and I want to get the coroners to agree that they're going to support the Muslim community in the correct way. And if there's any doubt on that at all, then I'm going to be very annoyed, and I'm going to speak to everybody I possibly can, because, it's very important that we have, equal treatment for every religion, and, we should be respecting those rights and those expectations of that community. And the coroner service were questioned at length and were very evasive and did not give categorical guarantees about that, any of that, which I was very disappointed with. So I would like that on the list. If we can start a list, please.
Thank you, Adrian. As I understand it, they don't have the equipment to do it, so they've only got invasive autopsies. They don't have a machine to do it.
Yeah, that's what they said, but, they wouldn't put that in writing, I believe.
But Chair, we have many, many private hospitals with scanning facilities in Berkshire, and those could be used.
Yes, what we're talking about here is, a segment of our community which may not be the wealthiest, and what we didn't want to see was, sometimes some of the poorest individuals in our community being asked for £2,000 for, a non-invasive autopsy. And the coroner's service would not categorically say that they would not ask for a charge for a non-invasive autopsy, separate to whether it's a private hospital or wherever. They would not categorically say that. They gave us no guarantees about anything. And this is why we were so concerned in that meeting, and this is why I want to see the coroners back as part of the work programme.
Any more comments? Thank you very much, Alice. It's lovely to see you, even though you're there and not here. We'll see you in person when the weather gets better.
Thank you, Chair.
Thank you. Let's move on now to agenda item 47, which is Adult Services Quarter 3 KPIs. Is anyone... Oh.
Good evening. Hi, Beth.
Yeah, hello. Okay, over to you.
All right then, so here to present our quarter 3 KPIs. It doesn't feel like long since we were here last. I think we were here in January. So just to kick off with a bit of an update, the last time we came, we let you know that we received our date for the CQC inspection, Care Quality Commission. That took place last week. So thank you to Beth and to David, who were on the receiving end of an interview from CQC. So thank you for your time on that. They were on site for the full week last week. We haven't been given any indication of how that went, but the feeling was very positive. It was a good week. The team actually quite enjoyed the process. It was a nice opportunity to talk about the good things that they do. Sometimes we concentrate on the more negative aspects of the work we do, so it was a really nice opportunity to talk about some of the positive things that we do. We've got a follow-up meeting in a couple of weeks, and then we're hoping that will be issued with a sort of prelim report mid-May, we're hoping, so we might have an indication of where we are then. So it's been a long time coming, but at least we're at the other end now.
It made quite a change talking about it in real life than pretending here, didn't it?
I think so, yeah, absolutely, Beth. Yeah, and it was an interesting process, and you know, it's got us all thinking quite a lot about things. So I think it was very useful. So just moving on to our quarter 3 report. So if we just look at page 57, we can see that out of the 8 KPIs, 9 KPIs, isn't it? Sorry. 7 were green, 1 red, 1 amber. So just to briefly touch on the greens, and then we can look at the red and the amber. So in terms of AS1, A and B, we're happy with our assessment processes at the moment. The weights are good, and the timeliness of completion of assessments is within a good range. So we're pleased with that, and we're on green for them. In terms of the percentage of new contacts, again, the conversion rate is good there, which shows that we are using our plethora of prevention services which are available to us with our VCS and community services. AS3, that remains consistent in terms of the proportion of people with a learning disability who live in their own home. That stands at 90% at the moment. So we are 38th out of 152 local authorities. So we are you know, doing very, very well in that area. If we skip over AS4 for a moment, and I'll come back to that. In terms of AS5, proportion of people receiving long-term care who have been subject to the review, that has improved, which is very, very positive. We're now at 71% of all individuals who are receiving a package of support have now received a review within a 12-month period. For those who've fallen outside of that period, we do have very, very clear data on how long they have been waiting for that overdue review, and 98% of those who are overdue a review have already received a welfare check to ensure that they are okay, and for us to be able to reassess the level of risk and if things have changed. And then just popping down to AS7, a proportion of section 42 inquiries which is reduced or removed risk, that remains at green. So we're continuing some very, very good performance in that area, as with AS8 in terms of the percentage of people discharged to the normal place of residence. and that remains at 91%, I think. So just having a look at the red one there, start with our AS4, that is the percentage of new admissions to residential and nursing care. And as you can see, we sort of go up and down with this measure, and it is an area of concern for us. And it's tied with a couple of things, really. The first noticeable thing is that we have, within the last 12 months, had a 4% increase in customers. Our assessments, social work assessments, have grown by 12%. And in terms of hospital discharges, that's grown by 34% in the last 12 months. So we know that the complexity of those individuals that we're working with is getting higher. And we know that people are coming out with high levels of need, and that is coming out in terms of the number of people that are requiring residential or nursing placements. Saying that, the target that we've put in place for Wokingham is very, very low. Our target is 25 for a quarter, and that doesn't always include our depleters, who we know, if we included, would be rising further. In terms of the number of placements in the last 12 months, Wokingham made 454 placements. Now that is still performing very, very well compared to the South East, which is at 556, and England, which is 560. So we're still doing well. We're 44th out of 152 local authorities. But I think the thing with this is we know things are probably going to continue increasing. We've had a conversation just today at the WHIP about whether we change that measure so that it's achievable and we're falling in with other local authorities. But the key thing for us here is around our avoidance, avoiding people falling, avoiding people getting into hospitals, etc. A concentration on reablement, so that we can get people up on their feet and we don't have a reliance on individuals needing to go into nursing care homes. And then the only other one, which is not green, is AS6. I wonder, Lorna, if you just want to talk to that one.
Yeah, there's not a great deal to say on this one, but it relates to CQC registered providers that are rated good or outstanding. So that's our residential care homes, nursing homes, and domiciliary care providers. If you look across the whole year, it's another one of those that goes up a little bit, goes down a little bit, but broadly across the 12-month period, it's fairly static. We will not see a lot of movement in this because of the reduction in the number of CQC inspections that happen every year. If we go back to 2016, which is, I think, when they were at the peak of what they were delivering, they were doing about 23,000 inspections a year. Post-pandemic in 2023, that had gone down to below 7,000 a year. And I think if we look at 2024, it was below 2,000 a year. So the gap between inspections with CQC is becoming longer and longer for that part of the sector, which is why we're not seeing a great deal of movement. So we actually use a much more, I suppose, accurate benchmark, which is really the work that our care quality and safeguarding teams do in terms of having very up-to-date intelligence about what's going on in all of the different settings. And we use that as our barometer for safety largely. Off the top of my head at the moment, I think we've got one setting on a red flag, which is an embargo. And we've got two settings which are on an amber flag, which is placed with caution. All of those three providers are working collaboratively with us, which is all about driving up quality in those settings. Of course, the downside of that is because CQC work on a risk basis, where they see that we've already done the work to stabilise a setting, it will go down their priority list for re-inspection. So, you know, it's a bit of chicken and egg, but the way we approach it in Wokingham is, you know, we focus on the risk, we deal with the issues as they present, and we kind of leave it to the regulator to, you know, to work out their own schedule. but we do work really closely with the CQC, got a strong relationship with them, and you know that pathway does work really well in terms of our care quality.
So that's the whistle-stop tour through the KPIs. But we're happy to take any questions if anybody needs any more information about anything.
Hello, thank you for that explanation about AS6. Particularly, I don't think I picked up before that one nursing home is 9% of the total, which really skews it. And it is great to hear that, you know, you're able to really support and work with, because I presume this is a privately run nursing home, and it's not like the school situation when we've got a bad academy, we can't, it can be difficult to help it improve. Do you feel that, you know, with the support it's been given, if it was to be rated, you know, next week, it could achieve good? And the problem is that just that you're going to have to wait and wait and wait until they're actually assessed again for these KPIs to change.
Sure. So I'd answer that question in two ways, I think. In terms of the provider that is currently on a red flag, that has only fairly recently gone onto a red flag. So we are still fairly early in the improvement work with them. Having said that, they are engaging really well and fully expect that in the next couple of months, we'll see some really good progress. We do have other settings in the borough which are still flagged with CQC as requires improvement or inadequate, where we've completed our improvement work with them. And in those settings, I'm pretty confident that if CQC went into those today or tomorrow, they would find a dramatically improved picture. Does that help?
Yeah, that's good to hear. So, are there any, you know, I'll say residents, I was about to say patients, I wasn't clear if that was the right term, in the nursing homes that are red or that are, you know, have been placed there by Woking and Borough, or are we avoiding sending any of our residents there?
So with any home that's placed on an embargo, there'll be legacy placements. So people that were placed there before those issues arose. Where that occurs, we risk assess all of the residents in the home anyway. And we include self-funders in that. So if there isn't another commissioner involved, we would take responsibility for considering the risk in relation to those people. Our framework does allow us to move to a position of deciding to offer people to move to other homes, but we only do that where the risk becomes almost intractable and we're unable to make progress. So in terms of the home that's currently on a red flag, we're nowhere near that situation at the moment. They're working with us proactively. They have an action plan in place. We're closely monitoring that, and we're working together. It's probably about 5 or 6 years since we've had to actually consider moving people out of a residential or nursing home. And I think that's testament to the really good relationship we have with our providers, whereby we generally get really good collaboration with them right from the outset of identifying a problem. Ultimately, our aim is the same. We're all looking to deliver the best quality care, the safest care we can, and that's the kind of collaborative relationship we've really focused on building with providers, so that we go on a journey with them rather than using a kind of stick to beat them with, as it were.
Thank you.
It's really good to hear that we act as our own inspectors as well, so that before anything becomes very serious, we've cured it. And thank you so much for that, because we need to do that with inspectors coming rarely, should we say.
Yeah,
we need
absolutely.
to keep our own standards up, and I think we're very good at doing that. I think David would nod as well, listening to that, which he has. Thank you. Any more questions? Oh, you've got off fairly lightly.
Did Beth? Thank you.
Yeah, we'd like
Can I say, Beth, that certainly I'm very impressed with the management of the adult services team, that everyone does the best for all the people who work here. I mean, it isn't, as you see here with Lorna, it isn't just the people we support, but also the people who are self-funders and so on, that we also support and help. And I'm very impressed with all we do, and make it as positive as possible for them, even with our limited finances.
Thanks for saying that, David, because we don't say thank you often enough to our officers. And I phoned up this afternoon and it said, please be kind. And so I said, if I was able to, I'd give you the afternoon off because the sun's shining. Because I'm like that. But I think we need to be kind to our officers. It's not an easy job always. Are you ready to carry on? Are there any more on here that you want to go through?
Oh, no. If there are no questions, we've given the highlights. So unless there's any other questions, we're happy not to go on.
I'm sorry, but Lou spoiled all that. Lou.
It's actually a question for you, Beth. Just while we're on KPIs, where do the public health KPIs get scrutinised? Which committee do they go to?
I haven't a clue.
Sorry, could I say OSM looks at some things, but we propose to OSM that it should be recommended that this committee looks at the public health, and that will be, I hope that's being added into the area that this committee will be looking at. The new committee in May could still be the old us all, but yes. So children's services look at the children's ones, adult services had been looked at here, but public health wasn't scrutinised in detail, and Adrian and I put that to OSM and it was agreed.
Jyoti, you wanted to come in?
Yeah, just to ask about a lot of our measures are often in arrears, 3 months in arrears. For example, our smoking cessation data, it takes 3 months to get a quit all the way through the system. And there's often a lag for some of the more higher level areas. It can be a year or 2 years delay in terms of getting the data. So I just wanted to check the frequency within which you want to see our KPIs.
We certainly look at KPIs at every HOSC meeting, but yeah, which is quarterly. We might want to talk about that and see if we need to change it and use your experience and wisdom in advising us on that.
Okay.
I don't know what David thinks.
I think that public health ones might be better every 6 months or every year, because as Jyoti says, it's that they're often so much behind that almost you don't know what's happening now because they are so far behind. But certainly it's useful to look at them, but I'm not sure that they're as valuable as they should be, because they are, in arrears by quite a way.
Perhaps we could take that offline and see if we can improve the way we look at them so that they're more relevant to these meetings.
I think that's a good idea.
Great, thank you.
Yeah.
Thank you.
Well, I would say that the way the KPIs are presented with the narrative, the detail, is vastly improved. I think between Adrian and I, we've been chairing this committee for quite a long time, and it's improved and it's improved. And I think perhaps the reason that there's slightly less questions sometimes is because you are giving us lots of answers in the narrative, but we do need to look at this each quarter at HOSC. I think it's a very valuable thing to be done.
Thank you.
Okay, let's move on. I've lost my place on the agenda now. It's much easier with paper,
Forward programme.
Oh, the forward programme. Thanks, Madeline.
So we've got one more meeting for this year. So we've got the meeting in April, the additional one. So we've got quite a few items on that. We've got the winter pressures preparedness, the further update on the update that came to November, basically how measures went. We've got the adult social care workforce strategy, the domiciliary care, including the market provision statement, and vaping in school-aged children. And we were going to also invite the children's services members if they wanted to sit in on the vaping element. I was going to suggest as well that we also, obviously, we've had some items suggested with the work programme, going to the management committee. We've had some suggestions from members as well that we try and put together a work programme for the new municipal year before we get there, so we're prepared. So if members would be happy to do that offline. If anyone else had any suggestions that they want to put forward, obviously Councillor Mather suggested about the coroner's service. If anyone had anything burning that you'd like to raise now, please let me know.
Okay, thank you very much. I think that is the end of the meeting. Am I right? Sorry? The action tracker. Oh, sorry. Yep, go on. Right, action tracker. Do you want to take this, Madeleine?
Yeah, sure.
So in fact, the coroner's service is on it.
Coroner's service is on there. So we have a few items still on there. Obviously, I'll just hop around if that's okay with everyone. We have the first one, which came back to 2023, about the suggestion that the chair of the Bob PCN Foundation be invited to a future meeting. So we have that currently on the list of items to be scheduled for next year. So perhaps if we try and pick that up as part of the work programme scheduling. Mm-hmm. The introduction to health and social care officers, that was from 2024 in July. Again, connected care system, did members still want an update on that? Okay, we will try and schedule that again at the same time. The all-age autism strategy is scheduled to come back in July, so that will be put in. And there was a request about more information on the NHS app and information's being available to individuals. So again, we could look to tie that in. So again, moving on to the next page, we have about the items which have either been covered today or on the next meeting. So the vaping, the RBH and the adult social care workforce strategy, a market position statement, and the winter pressures preparedness. And then on the last page, just to kind of highlight the items have been completed. But if there's any points that anyone wants to raise that I've missed, please do let me know.
The oldest item, when the chair in November 23, should be you, I guess, Adrian, had suggested we invite the chair of Bob PCN. I mean, I'm sure you've tried. What? Tell us the story.
It's more that other items were scheduled first, so it's we could still definitely ask for that item. It was more space on the agenda rather than any kind of lack of interest on their part.
Because it's involving people from outside that we invite and you ask and they just sort of
it's not on a lack of interest on other parties. It's the way that we've scheduled other items.
Thank you.
Thank you very much, everyone. I hope it's not too cold when we go outside. I fear it will be. Nice to see you.